Asthma is a chronic inflammatory airway disease defined by sudden, reversible episodes of airway narrowing. An active asthma attack triggers three distinct physical changes. The airway smooth muscle clamps down in a severe bronchospasm, the inner lining swells with edema, and glands flood the narrowed space with excess mucus. This reaction starts when a trigger like pollen, pet dander, or heavy exercise hits hyper-responsive airways. Mast cells release histamine, setting off a rapid chain reaction that locks down the respiratory tract. The crucial clinical distinction, and what separates it from chronic progressive diseases like COPD, is that this airflow obstruction is entirely reversible. That physiological reality dictates how we sequence our emergency treatments. During an acute attack, you'll observe audible expiratory wheezing and severe dyspnea, as the patient struggles through prolonged expirations to push air past the spasms. Notice how ABG values shift. Early on, rapid hyperventilation blows off excess carbon dioxide, resulting in a low PaCO2, or respiratory alkalosis. But look below. A carbon dioxide level returning to normal during an active attack is a severe danger sign. This shift indicates the respiratory muscles are too exhausted to keep hyperventilating. The air trapping is worsening, signaling impending respiratory failure. To stabilize oxygen demand, instantly position the patient upright in a High-Fowler's position to maximize lung expansion and apply oxygen to correct the hypoxia. In the priority interventions list, step 2 is the critical pharmacological benchmark. You must administer a short-acting beta-agonist rescue inhaler, specifically albuterol, first. Once delivered, add an anticholinergic like ipratropium for further bronchodilation, followed by systemic corticosteroids to treat the underlying inflammation. When administering these medications, always give the bronchodilator first, wait, and then administer the steroid. Finish by having the patient thoroughly rinse their mouth to prevent oral thrush. This sequence ensures the bronchodilator opens the airway first, allowing the secondary controller medications to penetrate deep enough into the lung fields to be effective. If the condition continues to deteriorate despite treatment, the patient enters status asthmaticus, a severe attack that is unresponsive to standard bronchodilators. This leads to the most critical observation you can make. If that audible wheezing suddenly stops in a fatigued patient, it isn't an improvement, it's a silent chest. You must escalate care immediately, prepare for rapid intubation, and begin continuous nebulizer treatments alongside IV magnesium sulfate to force the airway smooth muscle to relax. In an asthmatic patient, silence means no air is moving at all. It is the final stage before respiratory arrest. Save these clinical pearls for your next rotation, and pause to read the disclaimer.